Good evening, everybody, and welcome to tonight's Facebook Live. My name is Alec O'Dare. I'm the Managing Director for Wound Care People. This evening's session is compression in heart failure. Is it harmful or necessary? And this evening's speakers are the wonderful Dr Leanne Atkin, who's a lecturer practitioner at the University of Huddersfield, Vascular Nurse Consultant at Yorks NHS Trust. And also, we are very pleased today to welcome for the very first time to a Facebook Live, Roo Byrom, who is a heart failure nurse specialist at York and Scarborough Teaching Hospital NHS Foundation Trust. Roo, Leanne, how are you doing?
Good, thank you.
In tandem and stereo.
Yeah,
exactly. And I know, Roo, you are particularly excited about doing your first Facebook Live, and you've already said
definitely
to do another 10 before the end of the year.
Yeah.
Brilliant. Okay, so listen, as always, you can see that we're still presenting these from our homes. So if we've got any technical difficulties, please do bear with us. We'll get those fixed straight away. Everything is working fine now. Certificates will be available via a link at the end. Please do make as many comments and ask as many questions as you like throughout the event in the comments section, because we'll be back after the presentation for a live Q&A. What I will say is a huge thank you to our colleagues at Essity for supporting this event, and thank you to my team for working this evening. They'll be there to support you if you've got any questions, as I said. This is a really interesting topic, and I know there's lots and lots of people already joined us this evening. I don't want to scare you, Roo, but you're presenting to a huge audience that will grow throughout the night, so good luck with that. But genuinely, it's a topic that certainly over the last 12 months has been something that I've been talking about, or people have been talking to me about even more. So I'm really looking forward to reading the comments from the audience this evening, and I'm really looking forward to watching the presentation along with our viewers. So without further ado, I'm going to hand over to Leanne and Roo, and I shall see you both after the presentation for the Q&A. Good luck, and thank you all again for joining us.
So good evening, everybody. It's our absolutely delight to be here with you this evening. So this session is really pertinent, I think, to anybody who either works with patients with heart failure or people that use compression therapy regularly on their patients. We know that there has been many questions and debate about the use of compression therapy in patients with heart failure. I linked with the amazing Roo, and hopefully we're going to demystify a lot of this for you tonight. So the learning objectives from this session today is actually to give you a really good basic understanding of what is the meaning of chronic heart failure. What does that mean in terms of symptoms? To really explore the different classifications that we use within heart failure, because you'll have heard many different terminologies, and hopefully we're going to be able to give you education about all of those and what do they mean to your clinical practice. We're going to discuss with you the link between chronic edema and chronic heart failure, and really discuss the role of compression. When is it safe to use, when it's not safe to use, and really give you some practical guidelines and some guidance in terms of scenarios about using compression in specific patient groups. So this session today is titled Compression Dangerous or Necessary? Because actually across the UK there is a common myth that compression therapy is not suitable for patients with chronic heart failure. And I've had this said to me many times in my clinical practice, both from generalist practitioners and even specialist practitioners, both in a specialist of compression therapy and heart failure nurse specialists. So I met the amazing Roo Byrom a few months ago now, and actually we got together, had a great debate about how this current scene is really confusing to everybody. So we've got together to try to demystify it. As you know, I'm the queen of pathways. I love a good pathway. I love a good algorithm. And actually what we've done is actually we've built on a lot of the information that was in the original Atkin and Tickle pathway, but actually made it pertinent for patients with heart failure or people who you suspect heart failure is. We've produced the document It's been published. The link will be up with you very shortly, and we've produced the pathway, and we're going to focus really on using that pathway in clinical practice throughout this session tonight. Because there's a real clinical challenge, because many of you will have seen that actually compression therapy is not routinely offered to patients with lower limb edema if they're thought to have a degree of heart failure. And even if you've got patients in established edema, compression, if they go into an episode of acute heart failure, sometimes that compression therapy is stopped. So we first started off between me and Roo to really try to discuss, why is this? And I think that actually the major reason why compression is not routinely used is that we've got a true fear of overloading the heart. We have a misconception, if you like, of how much compression can be applied to that leg, what happens to that fluid, and we are worried that we're going to push that patient into acute heart failure. When we started to talk about this, I think the one thing that both me and Roo recognise is that there is a huge lack of published evidence in this space. So what we've done is to try to provide some guidance to be able to be built on, to be used as evidence for you in clinical practice to help formulate how you're going to treat these patients. So, like with everything, before we go any further, when we're talking about heart failure, we really need you to understand what this terminology means. And therefore, I'm going to hand you over to the heart failure expert in my eyes, Roo, who's going to take you through what is chronic heart failure, how do you diagnose it, and what is the clinical symptoms. Roo, over to you.
Okay, thanks. Well, I don't know about expert, but I'll do my best. So I'm going to talk a little bit about heart failure. I've tried to keep it fairly simple, and I'll try and get through it quite quickly, because obviously what we want to do is try and focus on the pathway and how we're going to use it. So at the moment, it's estimated that there are about 26 million people around the world who have heart failure, a diagnosis of heart failure, and about 900,000 of them live in the UK. Obviously, it has a huge impact in healthcare delivery and healthcare economics, and it also has a huge impact, a profound impact on the quality of life of those people who have a diagnosis of heart failure and the people that they care about. It's what we call a clinical syndrome, and basically in very, very simple terms, it means that the heart is unable to efficiently pump blood around the body. It's typified by a certain number of signs and symptoms that I'm sure many of you are very, very familiar with. So typically, if you see a patient come into clinic, they will say that they feel increasingly short of breath. Perhaps they feel more short of breath on the night time when they're trying to lay flat. They might even find that they're having to sit themselves up more to be comfortable, to be able to sleep, or even sleep in a chair to get comfortable. They may notice that they've had quite a rapid gain in weight. They may also notice that their ankles and legs are becoming more and more swollen. They'll often describe profound fatigue and a decrease in their exercise tolerance. Now, we know obviously there's a number of underlying causes for heart failure, and I could go through those all night. Mostly probably in this part of the world, the biggest cause of heart failure is ischemic heart disease. But also obviously hypertension, valve disease causes problems, diabetes, arrhythmia. There are diseases of the myocardium themselves, so things that cause dilated cardiomyopathies and hypertrophic cardiomyopathies. And also there's inflammatory response, so we get myocarditis, and we see a lot more of that, particularly post-COVID these days. Whatever the underlying cause is, what typically happens is there's an insult to the myocardium, and that initial insult starts a cascade of responses, both physiological and neurohormonal. And initially those are compensatory mechanisms. So basically it's the body trying to get the heart to work a little bit more efficiently, but over time they become what we call a maladaptive process, and they actually make the heart function worse. So that means really our mainstay of treatment has been medication that actually inhibits that upregulation of those neurohormonal pathways. So a lot of heart failure nurses will know that we treat patients with ACE inhibitors, with ARBs, with beta blockers. More recently, we've been using drugs like SGLT2 inhibitors and Entresto. We've had good results with those, and they generally treat the background disease for heart failure. But obviously, avert symptoms, the shortness of breath and the edema, we use diuretics to treat those. For the mainstay of treatment is diuretics. In the last 20 years or so, also, we've had an increased use of cardiac devices to manage heart failure. So we see a lot of patients now who have cardiac resynchronization therapy pacemakers, and they essentially just improve the function of heart by helping with resynchronization of contractility. As heart failure nurses, we spend a lot of our time talking about lifestyle and how patients can manage their diet, have a low sodium diet, reduce their fluid intake, be aware of their fluid balance, make sure they're keeping an eye on their symptoms so they can notice if they're decompensating, and they can get in touch with their healthcare providers to let them know. And we also talk about the kind of exercise that it's safe for them to do. So when we talk about heart failure, there's a lot, as Leanne said, there's lots of different terminology. We can talk about diastolic heart failure, systolic heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and a mid-range ejection fraction. But just so that we can keep things moving, I'm going to keep things quite simple and talk about right and left-sided heart failure and how edema falls with that. So usually in cardiology, we use the measurement of ejection fraction, left ventricular ejection fraction, to talk about the degree of heart failure that somebody has. So typically, ejection fraction is the amount of blood that's pushed out of the left ventricle on systole. And typically for a healthy adult, you would expect about 50 to 70% of the blood to be pushed out of the left ventricle when the heart contracts. In someone who has what we would call severe left ventricular dysfunction, their ejection fraction would probably be about less than 35%. For someone who has a moderately impaired left ventricular systolic dysfunction, you'd be looking between 36 and 40%. And then a mid-range ejection fraction would usually be between 40 and 49%. And all of those fall under the umbrella of heart failure with reduced ejection fraction, or HFrEF, as it's referred to, or more simply, left-sided heart failure. There's also, as I said, you can have right-sided heart failure. It tends to be a slightly different etiology for right-sided heart failure. It tends to be more of a lung, a respiratory etiology, but right-sided heart failure can also be caused by ischemia and infarction, as left-sided heart failure can be. But predominantly, the main cause of right-sided heart failure is actually a development of the left-sided heart failure. So what you get is that buildup of pressure back into the lungs with the left side of the heart not working as well, and that feeds through to the right ventricle. The right ventricle becomes damaged, it becomes weaker, and therefore it's less efficient in pumping the blood up to the lungs for that oxygen exchange that's needed. And what you get when that happens is biventricular function. So both sides of the heart are not working very well, and then you will get symptoms of left and right-sided heart failure. And what are those symptoms? I think we're probably all really familiar with them, but basically it's very typical. Obviously, edema is a real typical symptom of heart failure. So that can either be pulmonary edema or peripheral edema. And edema in heart failure is the result of this activation of these neurohormonal pathways and the RAS pathway that I've talked about earlier. And essentially it promotes the retention of sodium and water. And if you add that to the addition that there's increased venous capillary pressure going on, and there's a decrease in onotic pressure, what you get is the fluid being pushed out from the vessels into the interstitial tissues. Pulmonary edema and peripheral edema are slightly different in the way that they're formed. So pulmonary edema typically is not so much about an excess of fluid, but it's more to do with raised pulmonary pressures, which make lymphatic drainage harder, more difficult to occur. And again, therefore, you get fluid being pushed out into the alveoli, which makes the oxygen exchange difficult, which causes that sensation of breathlessness, and that sensation that a lot of patients complain of, this feeling of drowning, which essentially in some ways they are. And peripheral edema is more to do with fluid overload and retention of salt and sodium. Edema is slightly different in left-sided heart failure and left and right-sided heart failure. So in right-sided heart failure, you get obviously the buildup of pressure from the blood in the veins and vessels that's coming back into the heart, and typically you get that blood stasis and venous and lymphatic hypertension. And what you tend to see with right-sided heart failure is that the edema is lower down below heart level, so you'll get the sort of really big legs, and often you'll see sacral and abdominal edema there. And in left and right-sided heart failure, you get that decrease in cardiac output, which means there's a neurohormonal response, there's the RAS response to that, which means that you get antidiuretic hormone production, and you also get that retention of sodium and fluid going on. Essentially, whatever type of edema it is, what you have is fluid where you don't want there to be fluid, and what we want to try and do is to get rid of that fluid as best we can. And obviously our mainstay treatment, as I've said before, is using diuretics. So that can either be thiazide diuretics, loop diuretics, or those together. But it is important to know there is a limit to how much we can use diuretics. This is a comorbid population. They tend to have low blood pressure, they often have a degree of renal dysfunction, so we do hit a ceiling sometimes with how much diuretic we can use. Heart failure is a chronic condition. It has an array of symptoms, there's a spectrum of symptoms, so some patients that I will see will do very, very well. They will have very few symptoms, they will be able to go to work, some of them will even be able to go to the gym. And then obviously some patients will be at the other end of that spectrum. They will be very fluid overloaded, they will be very, very short of breath, and they may need hospitalization for IV diuretics, and some of them obviously end up being end of life because of their heart failure. And we use a system called the NYHA classification system. That's the New York Heart Foundation classification, functional classification, so that we can categorize symptoms that patients have. And it falls into 4 categories, and basically looks at the way that people are limited during physical activity. So stage 1, class 1, is where there's no symptoms at all, really. People don't really have any problems. Class 2, they may have some physical dysfunction when they're trying to move around, but very, very little. In class 3, probably on any kind of physical exertion, they're starting to notice that they're getting a bit breathless and they're finding it very, very difficult to do those things. And class 4, they really probably won't be able to exert themselves physically very much, and they may even have symptoms of breathlessness at rest. Obviously, patients can move up and down the NYHA classification. We can see patients who come into hospital who are full of fluid, have pulmonary edema. We give them IV diuretics, we offload them, and they can go from being class 4 to being class 1 or 2, sometimes overnight. And obviously, it's not a completely ideal classification, it's quite subjective, and it doesn't take into account all of the symptoms of heart failure, but what it is in its favour is it's quite simple to use. So effectively, class 1 and 2, we would call that compensated heart failure. So those are patients who are stable and probably don't need any kind of medication regime change, they probably don't need any treatment. And then class 3 to 4 are people who we would class as decompensated heart failure, and it may be that they need medication changes, they may even need hospitalization. And the reason that I discussed the NYHA classification with you is because obviously when Leanne and I started talking about this and talking about the kind of patients that we wanted to target and that we felt would be safe, we used the NYHA classification to try and decide which patients would most benefit from compression. Is that over to you, Leanne, for the red flags? Do you want to talk about that?
Fantastic. So I think that you will with me and say, yeah, Roo is an expert of all of this, and hopefully she's really demystified what the differences of heart failure is, and actually what's the difference between these compensated and decompensated. You can sort of call that as stable compensated and decompensated acute. And the start of our pathway starts of recognizing when is there episodes of acute decongested heart failure. In other words, when is there a risk to that patient? And actually, the clinical management needs to be focused on managing their heart failure, not managing their lower limb swelling at that point of time. So the red flags for decompensated heart failure is an acute deterioration of the following symptoms within the last 7 days. It's that time frame that you need to be aware of, because that makes a big difference between our patients. So it's that last 7 days, an increasing breathlessness, either at rest or on exertion. The presence of that truncal edema, actual swelling of that abdomen sacral area. Increased amounts of reports of waking up in the middle of the night due to breathlessness. An inability to lay flat due to breathlessness, or a rapid increase in weight. Any of those symptoms over the next 7 days is what me and Roo class as red flags for an acute decompensated episode of heart failure. And therefore, there isn't a requirement for compression at that moment in time for those patients. The focus must be on appropriate medical management to get them out of that acute phase. So that's where the pathway starts. Number one, maintaining patient safety. The pathway then goes down to bring in what we need to be doing in terms of from a national wound care strategy point of view. Before putting any form of compression on these patients, we need to assess for red flags from a wound point of view. So therefore, that's thinking, is there any episodes of any issues of red flags? If not, we know the immediate and necessary care for those patients. The immediate and necessary care needs to be cleansing and emollients of the skin and the wound, application of an appropriate dressing with sufficient absorbency, and first line compression as up to 20 milligrams of mercury pressure there and then. So let's just recap. What are the red flags that we talk about within the National Wound Care Strategy? Well, these are the red flags. It's thinking of, is there any acute infection on the foot or the leg? Is there any evidence of acute or chronic limb-threatening ischemia? Is there any evidence of skin cancers? Suspicious of DVT? And obviously, we need to be screening any patient if we think they've got an infection for signs of sepsis. So we need to be comfortable at screening for the red flags for decompensated heart failure and the red flags of lower limb conditions that we need to send on in other places. But in the absence of any red flags, the National Wound Care Strategy says that we should be treating patients with lower limb wounds. So this pathway is not for patients with pure edema alone. This pathway that me and Roo's developed is for patients with wet legs, leaking legs, areas of ulceration, leakage and lymphorrhea. And if you've got any of those patients, we should be putting on mild compression of up to 20 millimeters of mercury pressure as soon as possible, as indicated from the recommendations from the National Wound Care Strategy. But what we also know we need to be doing is completing that timely holistic assessment within a maximum of 14 days, including that holistic assessment of the patient to understand their requirements and their risks and benefits of compression, assessing that leg for its suitability for compression in terms of what form of compression and what level of compression. And that assessment should also include some form of vascular assessment, ideally an ankle brachial pressure index or a toe brachial indices. And we should also be doing a detailed assessment of that wound, thinking about wound bed preparation, trying to escalate that patient towards that healing. So why is this 14-day time limit so important? Well, it's so important because we have a lot of patients out there who have started off with mild weeping, got diagnosed as having a wet leg, developed significant lymphorrhea, leg swelling that eroded the skin, turned into chronic ulceration, and turned into nearly a lifelong burden for that patient. Every single one of these pictures that you can see here is a significant burden, a burden to the patient in terms of pain, quality of life, a burden to the NHS in terms of cost and resources. But when you look at all of those wounds, you have to recognise each and every one of them started off as a small, simple ulcer. Did our apathy of care, did our fear of compression cause this direct patient harm? And I think we have to answer that question with, yes, we didn't do well. We did cause harm through our apathy. So when we're talking about compression, what we mean is strong compression. You've got to remember that compression therapy is a fantastic anti-inflammatory device. It is extremely potent in terms of what it does to that venous hypertension, those lymphatics, that chronic internal inflammation that's caused this weepage, this exudate, this ulcer. But strong compression needs to be of the correct dose. The correct dose is at least 40 millimeters of mercury pressure, so long as I've had an appropriate vascular assessment. So we know about that of compression, but actually when we try to put that together, considering patients with heart failure, there is still a few unanswered questions. When is it not safe to use? When is it safe to use and needed? And when is a staged approach needed? And that's where hopefully our new pathway is going to really aid your decision making. Really is going to help you in terms of considering which patient needs compression now, compression later, or compression as a staged approach. So I just want to take a moment and take you through this pathway, because I know it's brand new and to everybody. It's only just been published last month. So we've given you very clear guidance. The first thing that we're saying is that this compression pathway is suitable for all patients, whether they're in hospital, whether they're in community, and it's also suitable for any patients where heart failure is diagnosed and confirmed or also suspected. The first thing that we've been made very clear is if the patient is already established in compression therapy and has an acute episode of deteriorating heart failure, do not remove that compression. That compression, if you remove it, the legs will just fill straight back up again. The patient's having an acute episode. We need to keep that compression on, keep those legs as dry and as small as possible. So we've given you clear guidance that compression, if it's already established, does not need to be removed. It should be continued. The next guidance is basically if you've got a patient with suspected heart failure, and has got lower limb edema, lymphedema, leakage, lymphuria or ulceration, then we really need to be considering, have they got heart failure? Do we know this? Are they actually got a clear diagnosis? Or do they require the assessments and the investigations to confirm that heart failure? We use a lot of BNP bloods to be able to determine the level, and also we use echocardiograms as our first line assessment of diagnosis of heart failure. The next thing we simply ask you to do is to assess those red flags of acute decongestive heart failure, the same red flags that we've talked about already: the increasing breathlessness, the presence of truncal edema, the reports of waking up breathless, the inability to lay flat, the rapid increase in weight. If you've got any of those, the advice is do not apply compression, escalate to appropriate practitioner. The next thing is simply consider those red flags according to that national wound care strategy. If there's any of those red flags, again, the advice is do not apply compression, escalate to an appropriate clinician to treat that infection, investigate that chronic limb-threatening ischemia, investigate that DVT or that suspicion of skin cancer. But if there's no evidence of red flags from a heart failure point of view, or red flags from a wound point, a lower limb point of view, the recommendation is that you apply up to 20 millimeters of mercury pressure to both legs and arrange a holistic assessment, including the ABPI, within 2 weeks. We want that 20 milligrams of mercury pressure on there and then to help to stop that progression of the disease, to stop that lymphuria from happening. and we've given you indications of what that could look like. And then following that, we simply work our way down the pathway with the next question, is there any evidence of ulceration or lymphorrhea? If there isn't, you can continue with that 20 milligrams of mercury pressure. We need an assessment actually to determine what level of compression is required on a long-term basis. Maybe these patients also have a history of underlying venous and lymphatic disease. So you can continue with that 20 millimeters of mercury pressure, consider those things, because patients are safe to be kept in that level and there's no requirement for them to step up. But if they have got a patient with ulceration or lymphorrhea, we need to be aiming to get those patients into 40 milligrams of mercury pressure if we can. We want you to complete that holistic assessment built on the ABPI, and the recommendations for the ABPI is the same as they are in any document that you read. Below 0.5, refer to vascular team, stop that compression. 0.5 to 0.8, continue with that 20 millimeters of mercury pressure for a range assessment from a specialist who's able to determine the prominent factor. Is that venous or is that arterial disease? If the ABPI is above 1.3, we need to be thinking about other forms of assessment to be able to determine that arterial supply. That's for me where your toe pressures come in. You can assess foot pulses and Doppler waveforms, but they are relatively subjective measures. Wherever possible, we should be aiming for an absolute measure with an ankle brachial pressure index or a toe pressure. So hopefully the ABPI and toe pressure is within normal limits as documented between 0.8 and 1.3. And then at the point of assessment, so you've already got the patient in 20 millimeters of mercury, you're thinking about stepping that patient up to 40 millimeters of mercury. You've assessed the ABPI, you're safe to do it from a vascular perfusion point of view. Just before you step it up, we want you to once again assess that patient for signs of acute decompensated heart failure. If not, then this is the question of whether you need a staged approach or not. The questions to say whether you can put 40 millimeters of mercury on both legs at the same time is simply based on, is there any evidence of either acute cellulitis, are bilateral legs affected, or is the edema extremely soft and pitting? If there is any of those, we recommend a staged approach. That's because we've looked into the literature and these are the 3 factors that could actually increase somebody's risk of increasing the severity in terms of the overload of the heart. If there is any of these, we suggest a staged approach. That is putting one leg up to 40 millimeters of mercury pressure, waiting and seeing for 7 days. If there's no signs of any acute exacerbation of the heart failure after 7 days, you can put that next leg up to 40 millimeters of mercury pressure. If there isn't any evidence of acute cellulitis, if only one leg affected, or if you've got no soft pitting edema, you can go straight into 40 millimeters of mercury pressure there and then. So hopefully that helps to start to demystify. And what we want our guidance to do, though, is to be used by heart failure nurse specialists and compression experts and community nurses. So within this guidance, we've also given some clear recommendations of what type of compression can be applied to which patient. So if you've got a regular shaped leg with mild edema, compression hosiery kits are fantastic. If a patient can't actually apply or remove them, compression wrap systems can be really useful. Compression wrap systems are also useful if you need to reduce significant amounts of edema and you are not an expert at applying compression bandaging. Compression wrap systems are a great option for people, and anybody can apply a compression wrap system. The compression, where we need though compression bandaging or wrap systems, is where we've got severe amounts of edema or an irregular limb shape. Those patients are not suitable for compression hosiery kit. We need a period of moving, of intense therapy to remove that edema, to be able to cope with that lymphorrhea. Those patients should be in a form of bandaging. If a patient does want to self-care, that's where your compression wrap systems come in. Or if you can't apply a compression bandage, again, a compression wrap system is really good for you. So hopefully we've provided guidance not only on when it's safe to use compression, when it's not safe to use compression, but also giving you some guidance on which compression to use. What we're aiming to do is to have standardization across all our healthcare systems. So therefore we have this consistency when our patients move from acute services to community services. We have that continuation of care, and we have that consistency of message across specialists. So the heart failure team is not saying something compared to the vascular team or the community team. So hopefully we've provided you some really easy to follow guidance in terms of where and when you should be using these therapies. So we just want to sort of bring this to life to you, if you like, with a couple of scenarios to help you support with this decision making. So I'm going to bring Roo back by the magic of the television, if you like, to talk about patient scenarios. So Roo, if we can just think about the start of our pathway, if you like. So the first thing that we need to consider in our pathway is that patient got any red flags of an exacerbation of his heart failure? So this is an 81-year-old gentleman. He's been diagnosed with heart failure back in 2021. He's had a couple of admissions to hospital with increased breathlessness. He's on a whole boat of medication to help to control his heart failure. But his left leg has got increasing edema, and he's starting with a bit of lymphorrhea to that left leg. What do you think of that patient's condition?
Well, I mean, I think there's none of the red flags that we've talked about in terms of in the last 7 days, there's not been an increase in any of his heart failure symptoms that we'd be particularly worried about. Sort of a quick cursory look over his medication. He's on reasonable therapy for his heart failure. There's not vast amounts of changes that we could make there. His blood pressure is settled, but it's on the lower side as well, so that's something to think about. And his EGFR is not terrible, it's not perfect either. So for me, I think this would be a person who would be perfectly suitable to start some compression at 20 milligrams, possibly in both his legs, and then to reassess in 7 days to see if there are any of those heart failure red flags that we've discussed.
And even though he's had a couple of hospital admissions because of increased breathlessness, and he's got a diagnosis of heart failure, you're still quite happy? There's no red flags?
I would be quite happy with that, because unless his hospital admissions were in the last week, if his hospital admissions were a while ago and he hasn't had those increased symptoms within that last 7 days, I wouldn't say he was particularly entering a period of decompensation where we'd be particularly worried that he was hitting sort of class 3, 4. And also, you know, looking at those legs, as little as I know about things like that, I would say that he's probably going to benefit a lot more from having that small amount of compression than as not doing anything at all. And I think, like we've talked quite a lot, haven't we, Leanne? The reality is that 20 milligrams of mercury pressure is not really a great deal, and it's certainly not going to shove a load of fluid back into the circulation and send it whacking back up to the heart, which I think is one of the things that people worry about. So I think for him, it would be best that he was put in compression, and obviously that his heart failure was monitored closely, but definitely I think he would benefit from the compression.
And if you go through our algorithm, that's exactly what it says, really. There's no assessment of any red flags that's concerned in terms of heart failure, and there's no red flags from a compression point of view in terms of the National Wound Care Strategy Programme recommendation. So, you know, therefore, the requirement is that this patient needs some form of compression. He has extensive lymphorrhea. You've seen the size of those legs on that assessment. So what we need to do is to put that patient into 20 milligrams of mercury pressure to both his legs straight away. We need to arrange that further vascular assessment within 14 days. If the vascular assessment is normal, we need to assess, do we need to do 2 legs or 1 leg? At the moment, there's only 1 leg that's been affected. There's no episode of any cellulitis. The edema isn't pitting. So actually we need to get that leg into 40 millimeters of mercury pressure as soon as possible. That's going to reduce his edema, help to improve the lymphorrhea, and reduce the risk of chronic ulceration forming. So On to scenario 2 then, Roo. So this is an 80-year-old lady who has been diagnosed with heart failure 3 years ago. She's got an ejection factor of less than 40%. She tells us that she's been having increasing breathlessness over the last 2 weeks. In fact, she's now sleeping with 4 pillows. She's waking up breathless 2 to 3 times a week, and actually last week she was able to sleep through the night without any problem. She's feeling increasing fatigue because her sleep is disturbed, and she's really, really breathless on a night time. What do you think?
Well, I mean, I think she's a real clear case, isn't she, of someone who is obviously decompensating their heart failure. She's got sort of all the classic signs. She's got increased PND. She's having to sit up more to be able to sleep comfortably, which is suggested that there's probably some fluid, some pulmonary edema. She's fatigued. She's got that nocturnal dyspnea. So for this particular lady, I wouldn't be particularly happy to put her in compression at this time. I think probably what she needs is a referral to the heart failure services, whether that's through a GP or a cardiologist. She might need another look at her echocardiogram. It's been a while since she's had one done, so I'd probably want her to try and be compensated from a heart failure point of view before we moved into using compression.
And if you put that together with this picture of her wound, she's got swelling up to her thigh, the edema is relatively soft. She's had this chronic area of ulceration for the last 2 months, but she's not been in any compression. So that's the key to me. If she was already established in compression, we wouldn't be stopping it, but it's certainly not the time to start compression off. The pathway is quite clear. This lady's showing signs of acute decompensated heart failure. Therefore, the recommendation, as Roo said, is do not apply compression. The time is not now. Escalate to that appropriate practitioner. As soon as her symptoms are stable, though, we need to get that patient into 40 millimeters of mercury pressure as soon as possible. That leg ulcer is not going to heal without any form of compression.
Yeah, and as again, it's about having a look at, isn't it? Because the medication is probably suboptimal, and certainly she's on amlodipine, which I think probably you as a vascular nurse and me as a heart failure nurse would look at and think, no, stop the amlodipine as soon as you can. Calcium channel blockers are not great in heart failure patients. They cause swelling in the lower limbs. So if we can stop it and find an alternative, that's a really good start as well there, I think.
And I think that's a great take-home tip for any of our community practitioners out there. If a patient is reporting lower limb edema, do a quick medication check. If they're on amlodipine, that's going to be it's going to be exacerbating that lower limb swelling. If you are not a prescriber or familiar with these drugs, do not stop it. What you need to do is to escalate that back to the GP, the heart failure nurse, and point it out that this medication's known side effect is lower limb edema. The patient is presenting with increasing lower limb edema, and you'd like that therapy to be converted to something else. There's many more nicer drugs and more effective drugs out there these days than amlodipine. It is one of my hatreds, is amlodipine. So finally, there's 4 of these, and we did this last time too. And the scenario number 3 is a 75-year-old gentleman who's under the district nurse services, who's been referred for lower limb management. The patient presents with breathlessness on mild exertion, and he's not going to bed on a night time. He doesn't like laying flat. And on discussion, it's because he's had an increasing amount of breathlessness over the last 4 weeks. There's no previous diagnosis of heart failure. His only past medical history is that of hypertension, and he's currently in compression bandaging. What should we be doing with that patient, Roo?
Well, as I think you've sort of made quite clear, I don't think we should be stopping compression bandaging, but obviously he is showing some signs that he could be in heart failure. We don't have any definite diagnosis, so this is someone that you would certainly want to have investigated for heart failure, but obviously he's got quite nasty looking wounds on his legs, so you don't want to take that compression off. So one of the first things that you'd want to do is put him through his GP or his cardiologist. I imagine it's easy to go through the GP, probably get a BMP done in the first instance, see if that's elevated, and if it is elevated, obviously then you'd want to move on to get him an echocardiogram to really have a look and see what's going on with his heart function. But as you've made quite clear, I wouldn't I wouldn't personally want to stop compression at all, and I think that's a sensible approach.
And that's exactly what the pathway tells you to do. It's quite clear. If the patient's already established in compression, do not stop that compression. We do need to be considering that diagnosis, because that gentleman is presenting with signs of heart failure, increasing breathlessness, doesn't like going to bed because he's breathless. We need to ensure that patient's got an accurate diagnosis and therefore accurate management. BNP is a fantastic little blood test. It's just a simple blood test, and it can actually help us to diagnose if there is heart failure present and what degree that heart failure is in terms of severity. And it's not 100% selective just for heart failure, but it's a great start if you're considering a patient has got heart failure. It is just a simple blood test that anybody can request.
I mean, it's very effective as a rule out, obviously, because if it's below 400, we tend to think that there probably isn't any heart failure, and above that we start to think that there might be. And it's a really good prognostic tool as well. It, you know, the higher it gets, that usually the worse the heart failure is. So it is really good. But what's great about it is it's reasonably readily available these days, so people can get it in the community. Obviously it can take a lot longer to get an echocardiogram, so yeah, get a BNP if you suspect anything.
And finally, the final scenario is a 60-year-old lady who's had heart failure for the last few years, and she's on a whole boatload of medication, including that amlodipine. And the community nurses have referred because she's had some new trauma to that left leg only 2 weeks ago. And then on top of that, bless her, she's got a spontaneous area of ulceration to that right leg. She's got high volumes of exudate pouring out of these. She's got soft pitting edema of both of her legs. So what are we thinking from a heart failure point of view, Roo, for that?
Well, again, a medication is probably suboptimal and could do with having a look at, but I think she's also, looking at that leg, it's quite obvious that she's probably in need of some compression as well. And I think if we follow the pathway, it's probably a staged approach. But I think what this brings together is that we can do those things. It's in tandem, you know, they don't have to be done separately. We can do them together, so we can get her in a little bit of compression and hopefully start to help with that wound healing, but also what we can do is get the heart failure services involved and get her investigated. I mean, she has got a diagnosis. Again, it's been quite a while ago, but she obviously needs some help. Her medication is suboptimal. We want to get her off that amlodipine. Metoprolol is not the best beta blocker to be on. So it's about that joint working, isn't it? Getting the heart failure team involved, getting the district nurses involved, whoever it is going to do that compression bandaging and working together, and know that those two things can fit together, I think.
Absolutely, and I think the more joint up working we can do with our heart failure specialist nurses, you know, is fantastic. But I think even if you are that sole practitioner, you are safe to put compression on. You need the assistance of management of that patient, but there's no red flags for any heart failure acute episodes. There's no red flags for any lower limb episodes. She needs immediate compression to both of her legs of 20 millimeters of mercury. We need to arrange that ABPI, and then she needs that staged approach of compression. Get one leg up to 40 milligrams of mercury, wait 7 days, reassess for those acute flags, put 40 milligrams of mercury on her other leg. The pathway helps you to work throughout all of this to make it a little bit simplified for you. So in answer to the question, compression is in heart failure, yes, it's necessary. It's always necessary. If a patient's got lower limb edema with leaking lymphuria, wet legs, or ulceration, compression is needed. We just need to maintain patient safety. We can do that by a staged approach, by ensuring no acute episodes of heart failure, getting them on to 20 millimeters of mercury as soon as possible, stepping them up to 40 milligrams of mercury when also appropriate. There is no evidence whatsoever in the literature of inducing harm. Like Roo said, if you're going to put strong compression on, it's not like pouring litres of fluid into the circulatory volume. We know more and more actually that when we move the fluid from the leg, it actually goes back through the lymphatics rather through the venous system. Therefore, you're not increasing the actual overload of the heart. We have to remember that our apathy is not harm-free. No compression with wet, leaking legs and increasing areas of ulceration is not harm-free. We need to be thinking of it slightly spun round in a different way. patients with heart failure are highly likely to going to require long-term compression therapy because of this cycle of edema, risk of ulceration, risk of leakage. The sooner we can get those patients into established compression therapy, the better their outcome's going to be in terms of a lower limb perspective. So we need to ensure that the management is optimum not only for the heart, but also for that lower leg to control that edema, keep that skin lovely and soft, keep that compression on, keep that leg small. So hopefully you've found that interesting. I'm sure there will be some questions relating to this, because whenever I present, I get questions on heart failure and compression, and that's the reason why me and Roo's brought this together to you. So we'll welcome any questions, and I'll hand back to Alec. Thank you.
Thank you, Leanne. Thank you, Roo. Wonderful presentation. I know that I've been watching it on another screen as well, just watching all of these comments come in, and there are hundreds and hundreds of comments and lots of questions. So you're quite right. Lots of people want to ask you both some questions. Before I do that, before I get over to the Q&A, there are just a couple of calls to action from Essity. There's lots of things that were talked about during the presentation that Essity can support you with, and they're things like their resources they've got available, such as their path education. They've got some bite-sized learning. They can support you with pathway development and various other things. All you need to do if you want to contact them is contact concierge.service@essity.com, or your local Essity account manager, and they'll be able to get in touch with you and basically be able to discuss with you how they can support you with any of those things. So I'm going to get straight onto the questions, because we've got just under 10 minutes, but there's quite a lot of them here. So the team have been sort of sending through the most relevant ones, or not the most relevant, that's the wrong phrase, but basically the first ones. The first question is, what made you choose 20 milligrams of mercury pressure of compression with no red flags of heart failure?
Okay, so we didn't, I think the quick answer, I'll take that one, and we'll make our answers short and brief so we can get through as many questions as possible. We didn't choose it. It's what the National Wound Care Strategy suggests from their clinical recommendations. We thought if we're going to do something, we should just be in line with that rather than cause additional confusion of a different measurement. So we've just taken the 20 as written within the National Wound Care Strategy. I know, because I was also part of that authorship group. You've got to remember that 20 is such a low level of compression. It's not really going to impede on arterial supply to the tissues, and it's certainly not going to push much back into the circulatory volume from a heart failure point of view. That's why we chose the 20. 20 is sort of flight sock territory, right? No, flight sock territory is more like 10-ish, 12-ish. 20 is either British Class 1 stockings. There are some compression wrap systems. If you put them on and you've got a measurement, you can get to 20. There are some compression bandages, but be careful. If the reduced or light compression bandage gives you 23, it's outside of the scope. The scope is very much 20 maximum. So you've got to understand what requirements and what options you've got within your local service of delivering that 20. There's many available. Essity will tell you exactly how much their stockings give you on a lower leg in terms of what's safe to use at that point. Brilliant. The second question is it's a fairly broad question. This is, what patient advice would you give when starting compression? So I bet we'll take it from two different options, Roo. So I'll go first, and I'll hand over to you from a heart failure point of view. The first thing is for me is to set patient expectations. So if you're treating a patient with a compression therapy and they've got a wound, tell them not to expect wound healing. That's not what comes first. The first thing that happens is you get edema reduction, then you get exudate reduction, then you get healing. So if a patient takes the bandage down after, or compression garment down after a week or two, and they go, the ulcer's still there, warn them that it's probably going to be. The first thing that we're going to see is that edema reduction, then the exudate going down, and then we should see ulcer improvement within 4 weeks. If you give them the expectations, it helps them to adhere to the therapies. Okay, and Roo, your thoughts?
Yeah, I think that you know, patient expectation is really important as well. And I think probably although this is quite new territory for any heart failure nurse, but I think it's probably quite important to try and explain that it's very much part of the treatment as well as perhaps as much as the medication is, which obviously we give an awful lot of advice about. We explain what the side effects are going to be. We explain that using diuretics is probably going to be a bit uncomfortable because they're going to be going to the loo a lot, but it's really important to adhere to it so we can get rid of that fluid. And I think in the same vein, it's quite important that we treat the compression therapy is just as important as the medication, rather than sort of like it being a separate, or its treatment rather than, you know, symptoms. So I think it's that really sort of explaining that it's quite an important part of their treatment, and that adherence to it is quite important if we're going to see an improvement in those symptoms.
Okay, thank you both. The next question is from Bianca. This is if a patient was already in compression when in the acute stage, would we remove the compression or keep this in place? Let's repeat that because I sort of stopped in the middle. If a patient was already in compression when in the acute stage, would we remove the compression or keep this in place?
Go on, Roo.
Leanne, do you want to take that first? Roo?
Shall I go first? So I think like I think we've reiterated it a couple of times during the talk. Hopefully we haven't bored you with it, but I think if someone is already in compression and then they go into acute heart failure, that you're better keeping them in the compression. That's not going to make any difference. All you're going to do is, if you release that compression, you're just going to probably see more edema developing. I'll let Leanne expand on it more because that's more her thing, but I think we're quite clear in the pathway that if somebody is already in compression and then they experience decompensated heart failure, not because of the decompression, that you should leave the compression in place.
Absolutely. Providing a reservoir for all the fluid in the legs by taking the compression off is not going to help the legs or their acute exacerbation of the heart failure. Keep it on.
Okay, I think keep it on is the answer.
Yeah.
Question 4, this is from Kate. Can we ask GPs for a BNP test if patient has extreme edema in their legs to exclude heart failure?
Yeah, absolutely. I think that's a really reasonable thing to do if you meet someone and they've sort of got fairly new swelling in their legs, and obviously if they exhibit any of the other symptoms that you might see, like the breathlessness or the increasing in breathlessness on a night time, I think definitely it's perfectly reasonable to request a BNP.
All I think I would say on top of that is to make sure that whoever's looking at the results is able to interpret it in the clinical context. So you've got to have a degree of understanding about heart failure to be able to understand what that test means in this specific individual case. Many GPs are great at that. Heart failure nurses seem to be a little bit better.
Okay, here's another question. When would it be safe to compress above the knee?
So yeah.
So the same thing. We haven't determined whether we haven't in our pathway. We haven't said the edema is just to the knee. So you can use our pathway whether you want to put compression to the knee or up to the thigh. We should never forget about the swelling on the thigh. We should always try to treat that at the same time as the lower limb swelling. You've got to understand your options a little bit more. I think compression bandaging up to the thigh is really difficult to apply, difficult to maintain, extremely time consuming. I personally prefer combinations of things. So like a thigh length class 2 stocking and a wrap below the level of the knee, or wrap devices onto the thighs. And there's lots and lots of combinations of how you can get compression right from the toes right up to the groin. And don't forget, we've also got tight options too if you've got swelling that goes further up. But that pathway can be used for swelling from the toes right up to the level of the groin.
Okay. There's another question here, which is an interesting one, which is, will this pathway be embedded into the National Wound Care Strategy? I'll ask you that, Leanne. In
the National Wound Care Strategy, you can't retrospectively do anything, if you like. They're the clinical recommendations. They've already put some guidance out there to say that we should be assessing patients for acute exacerbation of heart failure. Compression can be used in patients with stable heart failure. I thought we were still getting challenged on that. So therefore, that's why me and Roo brought this out to be able to embed it, if you like, to give our clinicians some help and some support in that decision making. What it is going to be embedded in is in a best practice statement that will be due out early next year in relation to compression therapy and heart failure. It will be in a best practice statement, therefore endorsed by multiple clinicians, and just to help you think it's not just me and Roo saying this. And we've got vascular surgeons, cardiologists, other cardiology nurses saying the same thing. It's going to be out in this best practice statement. And
when is that due out?
So we hope around Christmas time, maybe probably early next year. And it'll be available. It's a best practice statement from Wounds UK. If you follow me on Twitter, I'll be publishing it as soon as it comes out.
Brilliant. Okay, so listen, I think that sort of wraps us up for the evening in terms of the questions. As always, there's no way that we'd be here until next Thursday if we continue to just answer every single question. So for those of you that didn't get your question answered, we do apologize. But what we will do is we'll take all those questions, we create a lovely document which goes onto our website alongside the presentations with the answers, so that you'll be able to go on there and check to find out what response was given to the question that you asked. For those of you that want to re-watch any of this, then you can watch it on our Facebook page. You can also watch it via Essity's website in a couple of days, or you can just press back and start again from the beginning if you do so wish. Can I just say thank you very much, Roo. It's been a pleasure to meet you, and it's been you're just like a natural. Leanne's obviously rubbed off on you. It just came across.
Yeah,
not a single nerve was
oh, there were nerves, definitely nerves.
Really? Well, it absolutely didn't come across. So I think the presentation,
thank you.
The presentation was fantastic, and the amount of questions that we've had and the amount of comments that we've had and the number of people who've been watching, I think we were over 850 at one point, is a testament to the topic itself. So it's obviously a very, very interesting topic. Thank you very much to Essity for supporting this and for bringing this content and education to the wider audience. And I'd just like to say that now that the weather has turned and where winter is coming, we'll be back with more of these. So please do keep an eye out on our schedule so that you can come and join us. There's nothing better than sitting when the nights get dark, than joining us for a Facebook Live to learn all about lower limb care, wound care, pressure ulcers, anything else we've got going on between now and Christmas. We hope to catch up with you soon. Certificate links should be available on your on the comment section at the moment. Leanne, Roo, everyone at Essity, everyone at Mole, everyone in my team, thank you very much. I'm going to go and find out who our new Prime Minister is, and I will look forward to catching up with you all soon. Good night.
Thank you.
Bye.